Good afternoon. Thank you so much for the invitation and more so for the opportunity to learn from your own journey in Alport syndrome. Unfortunately, I'll have to speak English because my Macedonian is not good enough. I have no disclosures with respect to this particular talk. However, I'm going to share with you some patient photos for which I have explicit permission. So let's start with family Z, 3 brothers diagnosed with Alport syndrome. The parents are of North Africa Jewish descent. The mothers had microscopic hematuria, mild proteinuria, preserved kidney function, and mild hearing loss. And we confirmed that they had X-linked inheritance of Alport syndrome. They presented at various stages of the disease. So the proband was a 12-year-old boy who presented with nephrotic range proteinuria, microscopic hematuria, bilateral sensory neural hearing loss, keratoconus, and stage 5 CKD. And the decision was to initiate hemodialysis. One second. This is our pediatric hemodialysis unit. Okay, so to start the hemodialysis on a 12-year-old boy, it takes a multidisciplinary team. The most important participants are the dialysis nurses, but also pediatric nephrologists, invasive radiologists to put in central venous lines and to declot thrombosed AV fistulas, social workers, psychologists, dietitians, teachers, and therapists. The first step was to educate the child and the family, and the main role is to educate the parents so they better understand the condition and the treatment. And this is also true for the child. However, there is a specific emphasis here because we want to make sure that the child understands enough about his own care so he can answer very simple, basic questions. He can feel in control when he talks to relatives and peers. And one of the most important issues is that we would like to make sure that we discuss with the child the possibility that who they want to tell, what they wish to share, at what time they are ready to share, and oftentimes we do it in collaboration with the school staff. Patients on hemodialysis may experience academic gaps. Again, we have another opportunity to collaborate the hospital educators with the school staff to try and individualize education plans, tutoring and catch-up programs, and this is in parallel to cognitive and psychosocial support. The challenges of hemodialysis include long hours, the fact that it is repetitive at least 3 times a week. It may be stressful, at least in the very beginning. The hospital environment can feel medical, restrictive, and maybe intimidating. And obviously there is the emotional burden, which includes anxiety, loss of normal childhood experiences, and social isolation. But treating the illness is only half of the story. And in fact, we as healthcare professionals should make sure that we look for the second half and take good care of the second half. And the second half is in fact to develop the healthy part of every single patient. By supporting the healthy part, we foster resilience, confidence, and hope. But the most important thing is, in fact, to build coping mechanism, coping strategy, so that we improve not only adherence to treatment, but mainly that they grow to lead normal life. I'm not sure about the definition of normal life, but you know, normal. And to this end, we are all aware of medical clowns, but I would like to share with you 2 other projects. The first one is animal therapy introducing into the dialysis unit. On the left-hand side, you can see that this may include petting a hamster where the guinea pig is waiting. On the right-hand side, you can see a patient who is taking very good care of the medical needs of the rabbit. And here you can see a patient playing with a parrot and again cattling with a guinea pig. The second project I refer to is phototherapy. Obviously in pediatrics we call phototherapy something else, but actually there were 2 options. Option number one was to take pictures of your surrounding of the environment inside the dialysis unit. And option number 2 was, as you see in the upper panel, to create your own scene and take a picture of that. And shortly afterwards, there was an exhibition of all the work that was done within the dialysis unit, as you can see. The advantages for children are on various levels. Psychologically, they reduce anxiety and better mood, sense of normalcy. The physical benefits may include lowering stress hormones and improving vital signs. The social benefits are positive interactions, peer bonding, reduced isolation, and obviously improving adherence. But there are also advantages to families. You know, if you look at parents of patients on hemodialysis compared to those who do peritoneal dialysis, you'll notice that those whose children are doing hemodialysis actually build a support group because they meet at least 3 times a week, because those are very firm shifts, and they form a support group, and our social worker took it one step further, and she decided to do a guided support group during the same period of time that the children were at the dialysis unit. I'm just going to say something else about the staff, and then I'll refer to you. There are also advantages for the staff. The atmosphere gets to be more friendlier, easier rapport with children, and obviously it would lead to improved cooperation and reduced resistance during procedures. Okay, the second patient in this family presented at 6 years of age with microscopic hematuria, nephrotic range proteinuria, stage 3 CKD, short stature, failure to thrive, and metabolic bone disease secondary to chronic kidney disease. To this end, we established for children with chronic kidney diseases, we established a pediatric nephrology day hospital unit, which is an ambulatory unit, and there were 2 goals. Goal number 1 was continuity of care through various stages of the disease, that we would always have the same pediatric nephrologists, the same nurses, the same psychosocial team, the same administrator, and so on and so forth. And in addition, we'll try to prevent unnecessary hospitalizations. Thus, we're going to reduce disruption to family life. What we do in this day medicine unit, we provide treatment, procedures, and monitoring in an outpatient setting, and also exposure to all the subspecialties that take care of organ systems that may be affected with chronic kidney disease. One morning, as the mother and son came into the day medicine unit, the nurse actually noted that the mother was quite concerned, and when she asked her what was going on, she said basically that there are 2 new issues that they face, and she's not really sure how to deal with them. The boy's trying to take his medications, but he has a hard time taking them because they are liquid medications, and when they suggested to switch him to pills, apparently he doesn't know how to swallow pills. Number 2 was that actually developed a very strong phobic reaction to blood growth. So the next step was to move to action, and number 1 is obviously to reassure the mother and the child that this is a common encounter, but also to try and implement supporting measures like teaching strategies how to swallow pills. Usually what you do, you try to swallow very mini M&Ms, we call them lentil sweets, and also a stepwise approach to reduce extreme fear of needles. It then was closely followed by a dietitian, the pediatric endocrinologist with initiated growth hormone therapy, routine follow-up and by many subspecialists, in particular pediatric ophthalmologist and ENT for his Alport syndrome, cardiologist, and obviously the healthy side support team. The third son of this family underwent disease donor kidney transplant at age 15. He had preserved kidney function for 2 years until the age of 17 on triple immunotherapy, and at age 17 he decided to take drug holidays. He would try to experiment and see what happens if he misses 1 dose here and 1 dose there, and nothing really major happened, so he decided to try to be more intensive, to intensify the experiment, and miss more than 1 dose here and there, and he came in with elevated serum creatinine, and a graft biopsy showed that he had T-cell rejection, and he was admitted to the same ambulatory unit for pulse steroids. So thank God he regained kidney function, and 4 years later he has had preserved kidney function. Mom was responsible for medications and hospital appointments. He graduated high school and had a temporary part-time job. He still was figuring out what he wants to do next, and what we suggested is to engage him in a transition clinic. So transition, as opposed to transfer, is a very gradual preparation over years, so they become comfortable with switching to another team. We do know that during adolescence there is higher risk of missed medications and appointments, and this is, by the way, the leading cause of graft loss during adolescence. A transition clinic improves not only the health outcomes, but also confidence, independence, and continuity of care. Okay, there are a number of studies that look actually at the high-risk age window. And just to mention one of them, which was published about 10 years ago, and studied 16,000 patients who underwent kidney transplant during childhood or adolescence. And apparently in patients with functioning graft at age 17, 42% were in fact expected to lose the graft by age 24, the main reason for which is adherence to medications. And this is the high-risk age window, and this is actually the directive how to handle the transition clinic in our institution. I do acknowledge, though, that policies may change from country to country, from culture to culture, and sometimes only because of the requirements of the medical insurers. And I do know that in some countries you have to transfer your patient when they are 18, so you start the transition clinic early on between 12 and 14 years. Others would transfer patients only when they are 18 to 20. So the transition team includes obviously the patient in the center with pediatric nephrologist, nurse, psychosocial team, the parents, dietitian, and the doctor. Everything has to be individualized, including the educational sessions which focus on diagnosis and transplant basics, on medication management, but also on lifestyle choices like school, friends, travel, reproductive health, job partnership, and also navigating healthcare systems and insurance. And this is a very stepwise increase in child responsibility until they feel comfortable with the adult nephrology team. The parents also have to change their roles. They switch the role from being managers to being coaches and supporters. They should encourage independence while staying involved, and the most challenging part is letting it go. So the milestone for graduation from the transition clinic is if they know the condition and treatment, name the medications, doses, indications, being able to refill prescription and attend laboratories, and keep track of appointment. But the most important issue is to feel independent and comfortable with the transition. About a year ago, I was invited by the adult nephrologist in our institution to give a talk whose title was, "What should an adult nephrologist know about pediatric nephrologists?" So, among many other things, I told them that, you may meet patients at the 30s who come in for a failing graft and they've been on dialysis and underwent kidney transplant as children. Just bear in mind that their experience of being on hemodialysis is what you see in this picture. This girl, you probably appreciate that she's hooked to the dialysis machine. She's holding this tablet. She's very happy. So for her, this was hemodialysis days. So hopefully, this is the picture in adult dialysis units. And with this, I'm going to end my talk. Thank you very much.
Абстрактот на професорот јас бев одушевена од се она што во Израел се прави од тренинг од пациенти кои што се на педиатрија до возрастни пациенти, дозволувањето на меленичињата, дозволата да си има меленичиња во собите на пациентите, бидејќи и самата имам милениче и голем љубител на животните, тоа мене ме воодушеви, па и сите тие кловнови и занимации што им ги дават на малите дечиња, тоа е за секаков поздрав. Благодарам.